Good evening, everybody, and welcome to our fourth Paediatric Careers webinar. This evening, we've got a focus on education and educational resources and where to find them and so on and so forth. And we've got three great speakers for you this evening. We've got Dr. Roshni Mansfield, who's an F2 in London, who is also the Foundation Vice President for the UK Aspiring Paediatricians Society. We've then got Ian Lewins, who is a paediatric emergency consultant and also the podcast lead for Don't Forget the Bubbles. And finally, we've got Segan Ned as well, who's an ST5 trainee in London too. So without further ado, I will hand over to Roshni, who's going to kick us off.
Great. Hello, I'm Roshni. As James said, I'm a FY2 doctor and I work with UCAPS this year as the Vice President representing Foundation doctors. There are Foundation representatives for the UCAPS committee in nearly every deanery, so if you are interested, then do email UCAPS or tweet us. The Twitter handles at the end of this presentation to find out who that is so you can get in touch and get involved. I'm actually in the middle of a paediatrics rotation at the moment, which I wasn't meant to be on, but thanks to COVID, I got put on it. So one good thing's come out of this whole set of chaos. So that's been quite lucky. And I'm really enjoying it. So I'm going to be talking to you about some resources that I found quite useful while starting brand new on a paediatric rotation, and some ones that are just generally quite interesting for education, for your own education. And I'll touch on exams because it's coming to the time of year when people are applying for examinations. And also, I know some foundation doctors start to think ahead a little bit at this stage. So next slide, please, James. So as I've said, we'll touch briefly on examinations, not because there's any great rush to be doing them at this stage, just so that you've got some information if you're thinking about it now, and then some resources which are generally really useful and interesting, and then applications that I've found very handy to have on my phone, and finally we'll touch on the magical world of Twitter right at the end. Next slide, please. Okay, so just some general bits about exams in case you don't already know about them. So for full membership of the RCPCH, you have to sit 4 examinations. 3 of them are theory exams, which you have to take before you can then apply to sit the clinical exam. The 3 theory exams, I'll go into more detail about what they entail shortly, but they used to be Part 1A, Part 1B and Part 2, but now they've got different names to represent what exactly they're meant to be covering. You have to have done all parts of the membership exam to progress to ST4 levels. You've got your first ST1 to ST3 years to do this, to do them all. And in general, people tend to have done about 2 of the theory exams before they enter into ST3 at least, just so they don't leave doing all the exams to one hectic and stressful year. Next slide, please. All right, so very briefly, there's lots of information on the RCPCH website about how to actually sign up to doing any exams. So very briefly, it involves setting up an RCPCH online account. And once you have this, you then have to register for exams first. And this has to be done before the application period opens. So there'll be an application period which you get allocated on a first come first served basis for your exam, but don't leave it all to the last minute to start thinking about, because you have to leave at least 10 working days before the application period opens. But in general, it's said 3 to 4 weeks is the safest to guarantee that you have a chance of applying to sit the exams that you want to sit when you want to sit them. And then when the application period opens, you can apply to sit the exams. Next slide, please, James. All right. So because obviously we're living through a crazy time with COVID going on, thought it was worth just mentioning there are measures in place now to help people sit these exams safely from September and October this year. And I've included there the application periods and application dates and exam dates for the upcoming theory exams. I'm not going to touch on the clinical exams because I think that's quite far down the line for a lot of us, a lot of people listening. So the two options that you can sit in the time of COVID-19, you can either still sit your exams in a test centre, and this will be, of course, socially distanced with masks and, if you like, clear gloves, and lots of other measures in place to make sure that it's safe. Or alternatively, you can actually sit your exams at home or in a personal environment of your choosing, with online invigilation, which essentially involves having a camera and recording audio throughout the whole of the time you sit the exam, and the video and recording will be reviewed to make sure that there's no funny business going on in the background. For more information about sort of all the practicalities of all of this, you can go onto the RCPCH website. It's really easy to find the COVID adaptations because they're, of course, in bold quite early on into the exam section. There's an FAQ section which covers basically everything that I could have thought to ask. But of course, if there's more, you can always get in touch and ask. And there's also a really useful webinar, which was recorded earlier this year, so that you can watch, which is probably quite helpful to answer some more of your questions too. Next slide, please, James. Okay, so the three parts of the MRCPCH theory exams are called Foundation of Practice, which is the old 1A, Theory and Science, which is the old 1B, and Applied Knowledge and Practice, which is the old Part 2. The Foundation of Practice exam, you could theoretically sit this early in foundation years. It's meant to be sort of a slight extension of what was learnt in your undergraduate degrees. So in general, if you're into reading textbooks, then any undergraduate textbook is thought to be fine for this exam to help prepare you. So I've just put in a couple of examples that people found helpful when I was at medical school on the side there. But the RCPCH has also produced some clinical cases books for each of the theory exams, which I've not actually had a read through as yet, but they come highly recommended from colleagues I've spoken to. There are, of course, also question banks, and many people say that the key to passing these exams first time is practice your exam technique, and questions are very helpful. I've heard really good things about pass test, and some people also use on examination. I've put 1, 2, 3 doc and pass peds lower down there because I've not actually been onto the website, so I've not actually looked at those questions myself. They're certainly less frequently used from the people I've been speaking to anyway, but they are there, and if you're looking for extra questions, then absolutely more questions better. And then there are, of course, sample papers on the RCPCH website. The Theory and Sciences exam is more basic science, so it'll cover things that you might have learned about earlier on in medical school. And the RCPCH has produced really helpful textbooks. In particular, in addition to the clinical cases book, there's the Science of Paediatrics textbook, which is a pretty chunky but really well detailed book, really nicely laid out book, which will cover a lot of the core information for this exam. And I've heard it said that in general, you won't find very much in the theory and science exam that's not covered in that textbook. That's not to say there won't be questions outside of it, but it's a very helpful text to give you a grounding in the likely things that will be covered in that exam. And of course, question banks, sample pass papers, as we spoke about already. And finally, the Applied Knowledge and Practice exam. This one tends to be taken after the first two, although you can sit them in any order you like. The reason it's taken a bit after the other two is because in general, people like to have a bit of actual clinical experience under their belt before taking them. It's more helpful for this one because it does test some clinical decision making. But you could, if you studied really hard, of course, sit that whenever you like. This exam contains a special type of question which isn't in the other type of exam, the other two exams. It has n of many questions, so you might have to pick more than one answer out of several options. So you have to read the questions extra carefully, and also it contains images which the other two exams don't yet contain, although I understand that there is a move towards including images in all of them. Next slide, please, James. Okie dokie. So just for useful websites I found while I've been on Paediatrics, as well as just ones if you're interested in a topic and want to read up about it. The websites listed here, it's not an exhaustive list of all the websites out there that will be useful, but they're ones I really like. So don't forget the bubbles, which Ian may or may not mention later, but he's very involved with them. They have a really great interactive, very easy to read website, and it contains lots of different things. So evidence summaries and case-based discussion articles. There are also really useful quick reference tables. So I know when I was sort of clerking my first couple of patients, it was a really useful developmental milestones table that I could just refer to if you're feeling a bit rusty after medical school and seeing your first few patients. That's really helpful. So definitely check that one out. There's also Paediatric FOMED. So I definitely didn't know what FOAM stood for far too long. It's free open access medical education. And if you think of Life in the Fast Lane, that sort of thing, that they were sort of original versions, and Paediatric FOMED obviously covers paediatrics. It's also a very interactive website with lots of, so in the articles there'll be little quizzes down the side which are very helpful to keep you actively learning, and there are nice pictorial summaries of some key topics as well. And then Teach Me Paediatrics, I've not used as much as the other two yet, but it has nicely structured sort of disease summaries. And there are also some quizzes on there which are free. And so if you're not ready to commit to any sort of question banks or anything at this stage, but you want to do some reading, I can recommend that one too. And then, of course, there's subject-specific websites. DermNet NZ, I'm sure many of you listening will have used this at medical school and potentially afterwards to look up funny rashes that tend to stump us all. But so I definitely recommend that one, particularly if you want to practice looking at images, for example, for the AKP examination. And then Neonatal Tips is a website I came across very recently, which publishes very short and sweet summaries of just little tips about neonatal care and neonatal medicine. And you can subscribe on this website so that you receive them by email. So if you are the kind of person that learns ad hoc and on the go, that's probably quite a nice way to learn. But there's lots and lots of other subject-specific websites you might be interested in. Next slide, please, James. Nearly there. So I just wanted to cover some useful podcasts and videos that you might want to cover. So all of these have become very highly recommended to me. I have listened to Two Peas in a Pod and Dragon Bites myself. So Two Peas in a Pod is a podcast run by Dr. Lewin, so he'll be speaking later on. And it's a fantastic set of podcasts, and some of them will cover sort of general education about a specific topic. So, for example, hypoglycemia. Why does that happen? Who does it happen to? How do you treat it, etc. But it will also cover some of the bigger topics within paediatrics or systems. Or so, for example, there was a podcast about what the effect of paediatric consultant, like what is the effect of that on the shop floor, as it were. And there's also a really useful episode about sort of shape of training, how things might change in paediatric training over coming years. So definitely recommend Two Peas in a Pod. And then Dragon Bites is more geared towards paediatric trainees, but it's definitely worth being aware of early on when you hopefully go into paediatric training. But also there are some that are useful for our stage 2, so some that are about exams, preparation for exams, but also general things about how applications work later on and things if you're interested in looking ahead. And they'll also cover some topics that people find tricky to get to stick in their minds, partly for exams and partly for clinical work. So also really good podcast series there. And then just finally to mention, the London School of Paediatrics has a YouTube channel, and over the course of this summer, they've been running some sort of lecture series that's been run online, and all of their lectures have been recorded and put onto the YouTube channel. And I've tuned into a few myself. Very helpful. So particularly if you, for example, you're in a specific clinic and you want to find out about a specific area of paediatrics, so definitely check that one out. Next slide, please. Okay, finally, some apps for the job. Those of you who are already foundation doctors will be familiar with a lot of these already. when you enter any ward, don't go without having your BNF or BNFC on your phone, so you can flip between BNF and BNFC really easily. MD Calc is really useful for calculating all sorts of scoring systems, but also things like ideal body weight and things like that. Up to Date is, I find it really useful if you're lucky enough to be in either a university or a trust which will pay for your subscription. Then it's definitely worth it. So you can feel a bit smart reading up about some odd cases, or it will give you good little evidence summaries about what you should be doing for patients presenting with certain things. Then on the next line down, there's the that's the Resus Council app, and it has on it APLS and NLS, as well as more basic life support protocols. Really helpful if you ever catch yourself in a situation where you're caught off guard, you feel a bit unsupported, especially if you're new. It will sort of help. It's a quick way to sort of help refresh your memory in a tricky situation. And then RX guidelines, as it says in the tin, gives you some useful guidelines for specific conditions. The induction app is absolutely invaluable. You can get through to anyone in any hospital, mostly, except sometimes you have to go via switch, which is always painful. And then there's 3 on here which are more specific to paediatrics. So Heartpedia was recommended to me very recently, and it's very useful apparently for getting your head around difficult congenital heart disease, or structural heart disease as well. But that one's maybe not so useful for on the shop floor. But the 2 apps on the right hand side, Neomate and Billy app, are very useful if you're going into neonates for the first time. Some people start their paediatrics placements or F2 rotations in neonates, and Neomate basically helps you calculate doses and infusions and things like that. And Billy app will help you to plot bilirubin levels on the correct curves and things. So both of those are absolutely fantastic. So that's all I have to say about applications. Last slide, please, James. Okie dokie. So if you're not already on Twitter, I can't recommend it enough. I was a hard sell, and then once I'm on it, it's actually really, really useful. So there's a big world of medical Twitter out there, and within that, a world of paediatric Twitter, which is really helpful. If you follow some of the organizations that are on here, and then follow some of the people that they follow, and you'll basically end up with a feed that's really educational, and also sometimes advertises really useful job opportunities or other things that you just didn't know you needed to know about until you see it on Twitter. So RCPCH tweets is a no-brainer, as well as, of course, UCAP's tweets, I would say that. But then also there's RCPCH trainees, and then RCPCH and Us, I've put up there. It's a great organisation within the RCPCH, and it works to represent the voice of the children and young people that we hope to treat one day when hopefully we're all paediatricians. And then, of course, don't forget the bubbles and 2 peds in a pod, and Paediatric FOMED, which we've spoken about already. And then PaedSig is a good organisation to be aware of. Again, it's linked to RCPCH. It's a paediatric educator special interest group, and they run lots of conferences, and there's lots of opportunities to get involved with different things, and they do some question writing sessions and things like that. So keep an eye out on PaedSig. And then the final one I've put on there is the Education and Practice edition of Archives of Disease in Childhood. So some people have recommended to me that that's actually quite a useful journal, but also on Twitter, to help you revise for the AKP. So something to kind of have on your radar if you are thinking about doing exams later on. And then there are specific people who are really vocal and helpful in their Twitter sphere. So, of course, in addition to the 2 speakers that you're about to hear from when I finally stop talking, there's also a few, I've just picked 4 at random, but very interesting people to follow on Twitter. So Emma Coombe, who is the RCPCH trainee rep, and also she's chair for 7 BMA JDC as well. She's a great one to follow. And Alistair Munro, who's a sort of PEDS ID research fellow, and Damien Rowland, who's an honorary professor and consultant in paediatric emergency medicine, and Michael Farquhar, who is a consultant in sleep medicine. So all of these people I found really interesting to have on my Twitter feed. So without any more waffle from me, I'm going to hand over to the really interesting part of tonight's webinar. But thanks very much for tuning in for this webinar.
Thanks very much, Roshni. That was great. Really loads of stuff there, which is of great use, I'm sure, to everybody that's listening. Don't forget, there's also a RCPCH YouTube channel where you can see all these webinars played back as well. So yes, without further ado, we'll hand over to Ian.
Do you want to know the secret to happiness? Well, of course you do. The secret to happiness is this. A rich man went to a wise man and said, "Wise man, tell me the secret to happiness." And the wise man said, "The secret to happiness is this. Grandfather dies, father dies, child dies." And the rich man's horrified and says, "How can that possibly be the secret to happiness?" And the wise man goes, "Because it happens in that order. Grandfather dies, father dies, child dies." And that is why paediatrics is the best job in the world. And paediatrics is the most important medical speciality because we preserve that order. Next slide, please. So, hello, my name's Ian Lewins, and you can find me doing stupid things on Twitter at Ian Lewins handle. I'm a consultant in paediatric emergency medicine based in Derby. And as Roshni said, I run the Two Peds in a Pod podcast. I also look after the podcasts for the Don't Forget the Bubbles website. And I run a PEM infographics, which is a emergency medicine infographics website. I'm very pleased to be to join you today. And when Roshni asked me on to sort of come and talk briefly about something, I tried to think about something that I'd encountered throughout my career, and that's going to be about making rash decisions. Next slide, please. So there we go. We're going to think about rashes and an approach to rashes. Next slide, please. So I graduated in the last century, which is incredibly depressing. So this is me in the middle in 1998. And I always thought that I wanted to do paediatrics. And my paediatric attachment was really awful. I didn't enjoy it at all. But one thing stuck out in my mind compared to anything else far more. And that was one day when we were on the ward doing the post-take ward round. A child was brought up to the ward who had a non-blanching rash. And I vividly remember her face. She was a little girl, with little brown hair, about 4 years old. And in front of us, in the space of about 30 minutes, this rash spread rapidly. The child became increasingly unwell, had a cardiac arrest, and died. Next slide, please. And as you can imagine, as a medical student, that had a huge impact on me, seeing how quickly a child could go from being pretty well to being incredibly sick. And I think we're all familiar with this image of very unwell children. And that must be one of the things that scares us most. Next slide, please. And so the public have been informed a great deal about meningococcal disease. And there are lots of posters everywhere and a huge public health push to try and make parents and carers and families aware of meningococcal disease. Next slide, please. And I think we're now all very familiar with this idea of the tumbler test. So people are very comfortable with going, this is a rash that doesn't go when I press a glass against it, and I should be worried. Next slide, please. So non-blanching rashes are something I've seen throughout my career, which is now comfortably 20 years old. But we've got a real problem, because if you look hard enough, about a quarter to a third of children will have on their body somewhere a non-blanching spot. Now, clearly, we can't treat every single child who looks really well with a non-blanching spot. Otherwise, our hospitals would be full. And most of these children don't need any treatment at all. And the non-blanching spot is nothing to worry about. But of course, the problem is that this could be the start of meningococcal disease. So how do we go about deciding who's got something worrying and actually who's well and has nothing concerning at all. And when I started doing paediatric emergency medicine in 1999, we really didn't have a clue on how we should treat these children. We didn't have a guideline or a protocol to help us. So people cleverer than me at the time said, well, clearly we need a protocol, we need a guideline to help us with these children. And so I took part as an SHO in a spotty rash trial. And what that involved was every child who came through the door into the children's emergency medicine department with a non-blanching rash was entered into the trial. And the poor SHO had to document on a body map and measure every single non-blanching spot on the child's body. They then had to take some bloods, which was on a pro forma. But importantly, how you treated that child was left up to you as the individual. And guess what? We were pretty damn good at picking up the children with meningococcal disease. And in fact, in the study centre I was involved with, over a year, only one child with meningococcal disease was missed and was sent home. And actually, when they came back for their antibiotics, they were perfectly well. And what that tells us is actually our gestalt, our pattern recognition as doctors is really pretty good, because that's what I do a lot of the time. It's pattern recognition, and it's also risk management. And when people come to ED, that's a lot of what we spend our time doing, is saying, okay, I'm not quite sure what's wrong with you, but I know it's nothing serious. So risk management is very much part of this. So my approach to the child with a non-blanching rash is as follows. Next slide, please. We've got to ask ourselves and answer 3 questions. Next slide, please. Question number 1, is this child sick? Question number 2, can I make a positive diagnosis? And question number 3, can I safely discharge this child? Next slide, please. So question number 1, are they sick, is actually pretty easy. The child that comes in who's shocked, who's got poor perfusion, who's hypotensive, who's tachycardic with a rash, they're really easy. They're very poorly, but they're very easy to spot. These children are sick and we need to get on and treat as if they've got meningococcal disease. Next slide, please. So I've answered question number 1 and I've gone, well, they're not sick, they're not quite right, but they're not really poorly. They're not tachycardic or hypotensive. So the next question is, can I make a positive diagnosis here? Next slide, please. And the vast majority of diagnoses of a petechial rash fall into these 3 categories: mechanical, vasculitic, or hematological causes. Next slide, please. So, mechanical, what do I mean by that? Well, petechiae are essentially bits of blood under the skin. So we need to think about how that might be caused. Next slide, please. So here's a child who's been up all night coughing his head off, and mum notices the next morning that this child's got this funny rash around its eyes. The child's otherwise well and there's no rash anywhere else. This is a mechanical cause of petechiae. This child has coughed, raised the intrathoracic pressure and burst the blood vessels around the eyes. And this is a very typical appearance of around the eyes and often on the neck of a child who's either been coughing or vomiting. And actually, we don't need to worry about these children too much. Next slide, please. Sadly, of course, in paediatrics, there are more concerning causes of petechial rashes. This child's been assaulted, this child's been hit, and you can see where the finger marks have left a mark and a sparing area, and then petechiae next to it. So if you're seeing a child with a petechial rash, think, could this be a non-accidental injury? And people often say, oh, you paediatricians, you see non-accidental injury everywhere. To which the short answer is, well, if we don't look for it, nobody else will. Next slide, please. So we've thought about our can I make a mechanical diagnosis? The next group is this a vasculitic cause? Next slide, please. And the most common vasculitic rash is this rash. This is Henoch-Schönlein purpura, or HSP. And you might look at this rash and go, oh my goodness, this is meningococcal disease. But actually the clue is that the child is sitting there really quite well and really very happy. And typically in HSP, the rash is very much confined to the lower limbs and buttocks, and occasionally on the arms. So you'll see this a lot confused as meningococcal disease, but this is in fact a really well child who's got HSP. Next slide, please. And the final group of diagnoses to think about of a child with a particular rash is, could this child have some sort of hematological problem? Could this child have idiopathic thrombocytopenic purpura, ITP? Could this child have leukemia? And so it's worth, in these children who we've decided have got a particular rash, but don't quite seem sick, that it's worth doing some blood tests. Next slide, please. And as a rough guide, we could do some of these. We could do a full blood count, CRP, culture and PCR, clotting screen, a glucose and a gas. And that would be a reasonable baseline of investigations for this child. If I can then make a positive diagnosis of, for example, HSP, then the child can be treated appropriately and they don't need to be treated as if they've got meningococcal disease. Next slide, please. The vast majority of children, however, fit into this group. They're not septic. They don't have an obvious positive diagnosis, so they've not got leukemia or ITP or HSP. So we need to say, okay, risk managing, can I safely discharge this child? And we've come up with some criteria. Next slide, please. Which are these? So the child remains well, they don't deteriorate and become poorly in our department. The child doesn't have purpura, i.e. a big purpley splodgy rash. They are simply the pinprick petechiae. The rash that they came in with isn't rapidly spreading in front of us. And from those blood tests that we did before, the CRP is normal, as is the white count. If this is the case, then I can say to the parents confidently, your child does not have meningococcal disease, we don't need to treat and can go home. If, however, the CRP is elevated, or the rash starts to spread, or you've got a raised white count, then it's probably prudent to treat them as having meningococcal disease. And so these discharge criteria and this kind of guideline came out from doing the things that we did in 1999, the spotty rash trial. And we realised recently that nobody had really looked at these guidelines for quite some time to say, have things changed? Next slide, please. And so a study described below from published in Archives of Disease in Childhood in 2016 aimed to say, okay, we've got actually a couple of protocols. There's a NICE guideline and there's something that many centres use called the Newcastle, Birmingham, Liverpool guideline. They're different. So which one's better? And what they demonstrated was that the NICE guideline, whilst it had a sensitivity of 97%, was really non-specific, down at 50%. Whereas the Newcastle, Birmingham, Liverpool algorithm had a sensitivity of 100% and a specificity of 82% in the patients they looked at. However, this is old. This is old data, and something significant changed in 2015, and that was that we brought in the meningococcal B vaccine. So we need to go back and study this again. The infographic that you see on the screen comes from a website that I co-run. Next slide, please. Which is something called PEM Infographics. And many people find infographics a really useful and handy way of quickly learning things. And we've had contributions from a huge range of medical professionals, medical students, F1 and F2 doctors. So please have a look and have a think if you'd like to contribute to it. One thing that you probably noticed, or maybe you didn't notice, was that on all the slides that we looked at, all the pictures were of white skin. And this is something that's really come to the fore recently, and people saying, actually, what about black or brown skin? Because there's a big concern that children with black or brown skin are being missed with these rashes. And so I would strongly urge you to go and have a look at several really interesting websites and groups that are trying to challenge this and address this. And they include the Brown Skin Matters on Instagram, the Skin Deep project from Don't Forget the Bubbles, Mind the Gap, and Melanin Medics are all excellent resources. Next slide, please. So we've said that meningococcal B vaccine was introduced in 2015, and the data has almost certainly changed. And is our protocol now up to speed? I've gone in my career from seeing maybe 1 or 2 children every couple of weeks with meningococcal disease to hardly seeing any. I can think of 2 in the last 2 years because of vaccination. And so we've needed to go back and study this again. And something that's going to be published later this September is something called the PIC study. So it's the Petechiae in Children study, led by a guy called Tom Wakefield, done through Paediatrics, which is the Paediatric Emergency Research in the UK and Ireland. And this is a study that's going to look and say, of all the protocols that we're using, which is the best, which works. I've seen it and I'm embargoed from telling you what it shows, but suffice to say, nice does not come out well. Next slide, please. If you want to hear about the PIC study, as I say, I run 2 peds in a pod, and we spoke to the lead investigator, Tom Wakefield, Waterfield, sorry, about this previously. And Tom's going to come back on in September and do a podcast with us to discuss the results. So I'd encourage you to have a listen to that because Tom's an excellent speaker. That just about finishes what I wanted to say. I think paediatrics is a fantastic speciality. And if you remember the graduation picture I showed you at the start, let me show you what we looked like when we all met up last year. Next slide. You see, we don't stop playing because we get old. We get old because we stop playing. And paediatricians never stop playing. So not only is it the most important job in the world, it will keep you looking young as well. Thank you very much.
That's great. Thank you very much, Ian. Great talk. So we've got a couple of questions coming through now, but we'll take them at the end. So if anybody else has any other questions, do put them in the live Q&A bit. But before we get on to some questions, we'll introduce Segun, who's going to speak, our last speaker of the evening. Segun, would you like to unmute yourself?
Yes. Hello.
Great.
Hi.
Over to you.
Thanks so much, Ian. That was a really, really informative talk and a bit of a hard act to follow now. But hi, everyone. My name's Segun. As said, I'm a paediatric ST5 registrar in London. And this is, it must have been the takeaway. Next slide, please. So I presume by now, if you're still on the chat, that you want to be a paediatrician or you're at least considering it. And I think it's such an amazing speciality for so many reasons that I have, but maybe you're just thinking, I'm not really sure. I mean, babies are really cute. If we put the next, and children, they're really quite funny as well. And it'd be really lovely to be a paediatrician. I mean, you'd be happy all day, but maybe you're a bit worried. Isn't it going to be lots of coughs, colds, snotty noses, and tummy bugs? I mean, babies, they vomit. I mean, they still look cute, but they vomit. And what about all those parents asking about poos? I mean, they're probably lovely rainbow unicorn poos. But let's explore. Next slide, please. So let me tell you about Bob. It was the morning after the night before, on a sunny COVID lockdown morning. And Bob's family's favorite takeaway has just reopened. This week. I mean, the family are going all out. Next picture, please. So his plate was full. scoffed down a whole bowl of fried rice, chow mein, chicken balls, and had trifle too. The whole family joined in. It was great. It was really great. But fast forward to 3 a.m. Next click. Bob woke up. He was in terrible, terrible pain. Tummy pain was so excruciating, and he's vomiting. And he just kept vomiting and vomiting and vomiting. And suddenly, I mean, his mum just didn't know what to do. He wasn't really drinking. He just felt really tired and sick. So he had vomits. His mum brought him to A&E, and he'd had about 10 by then. It had initially been food, but it was clear. He had no diarrhea. In fact, he opened his bowels yesterday, she said. Usually he goes twice a day. Been passing a bit of smelly wind this morning, but I'm not really sure what's happening now. Didn't have any fever, but he'd been feeling a bit cold, shivers, and breathing a bit fast. His heart was really beating, and she just was really worried because he just seemed so lethargic. But he had been up since 3 a.m. And yesterday had been epic. I mean, the whole family had also done a socially distanced country outing. Bob had done 6 miles on his scooter. It was great. He was fine. He didn't fall over. He didn't hurt himself. He was totally well. Next slide. I mean, he was totally well until we got to the past medical history. Now, Bob did have a bit of a complex background. Next click. He had a condition called DiGeorge syndrome. Now, you might remember from your textbook days or iPad days, as it might be nowadays, a condition, a genetic defect where he has a missing part of chromosome 22. Many kids have so many associated features, and Bob had quite severe learning difficulties, so his mum gave most of the history. But he had a congenital heart defect, next click please, which meant that he'd had lots of operations over time. Bob was well now. He'd had lots of surgeries, and his oxygen levels were okay at rest, but he had to have lots of appointments. He'd missed a few in COVID, but he was doing okay. Next click. Also, he had some facial characteristics. Low set ears, small upper lip, a small jaw, and slanting eyes. And he'd had lots and lots of chest infections, ear infections, because his thymus didn't work too well. He'd also had lots of feeding problems. He'd seen a gastroenterologist so many times. He used to have a peg, but he'd not had to have it since 2018. He's doing really good now. Next click. Additionally to that, unfortunately, Bob had had not the best of luck. He'd had to have so many procedures, and operations have risks too. His luck had run out when he was young and had a liver laceration. And also he'd had cerebral edema, but mum reassured, I mean, he's now well. He's just a normal child. Slide 5. So onto the examination. Bob looked a bit peaky, I must say. He was really clingy to mum, but we examined his chest. It was normal. He did have a scar from his heart surgery, but that's to be expected. He didn't have any respiratory distress, good air entry. It was equal bilaterally. Sats were 97 in room air, and his breathing rate was only 24. He had a murmur. I mean, we expected that. It was kind of warm. He was okay. His cap refill was fine. His heart rate was a little bit up though. And the tummy, well, he was just being really clingy. He didn't really know what to do, and he just wanted his mummy. So he had a hug. We had a check. His tummy looks flat. He did have some pain, but he didn't really want us to touch him. So next slide. It must be the takeaway. Bob had a quick sugar check. It was 5.7, it was fine. We put him on a fluid challenge, 5 mils, diarylites every 5 minutes. But it's COVID, there's so much going on. A resus call came, he had to wait an hour. We came back, and Bob hadn't had any further vomits. He was okay, but he wasn't really drinking. Click. He'd only taken 50 mils. Time to do a gas, I think, and time to get some IV fluids up. Next slide. So now this is a tale in COVID time, so nothing goes to plan. Unfortunately, his complex medical background meant that he'd had lots of attempts at cannulas over the year, and it was really tricky to get a cannula in Bob. We just couldn't really manage. And that's when our friend, the vein finder, came in. Think Superman X-ray vision meets patients with secret veins. Click. So mid attempts to get everything together, something else occurs. We have another vomit. But this is not just any old vomit. Next click. This is a green vomit, a really green vomit, a bilious vomit. We doctors pause, we look at each other, we look at the vomit. This can only be one thing. We lie Bob down. Mum gasps, what's happened to his tummy? There's a fullness in his tummy. He was so skinny before. He's in so much pain. Well, the cannula goes straight in. We got a bolus in. We went for X-ray and we called the surgeons. Next slide. Now, if we didn't already have active minds, next clicks, we definitely had them now. Autoimmune, I mean, it's unlikely. Congenital, he did have DeGeorge, but why would he just vomit because of that now? Trauma, well, Mum said he was on the scooter, but he really didn't fall. And infected, well, it's got to be the takeaway. I mean, it could be another bug, but they all had it. And actually, Mum did say his little brother's got diarrhea too. It's got to be the takeaway. Vascular, gut ischemia is a bit too extreme for now. And we've checked his sugar, it's not TKA. Next click. Metabolic, I mean, it's unlikely he's got something new now. Inflammatory, well, COVID really is bringing us some crazy things right now. Who knows? Maybe it could be. Neurological, I don't think he's got raised intracranial pressure. And as much as he's not talking much, his mum seems to think he knows where he is. He just doesn't want to speak. Degenerative, let's just pass that. It's not that. And surgical, well, I guess it must be so. It's bilious. Next slide. Next slide. So his chest X-ray looks normal, but then we come to the abdominal X-ray. It's got lots and lots of poo in there. Now, there seems to be a small loop of bowel, and then it just stops. Well, Bob's on IV fluids. We put in an NG tube. There's not really much coming out, but there is a tiny bit of green still, and he's in pain. We called the surgeons again because we really need some help. It's time to go for CT. Next slide. Now, this is just a normal CT, an abdomen with contrast. Lots of bowel, as you can see. Now, as we said, Bob is not just any old guy. He unfortunately can't have contrast. Last time he had a cardiac arrest, so we won't do that. Next click. This is Bob's CT. Now, if you see the sausage shape in the middle of that picture, the shock and horror that we had, you'll soon understand. Because Bob has a closed loop small bowel obstruction. How? How could this be? A volvulus? How rare? It must have been the takeaway. That's all we get to see. The vomits, the wheeze, the poos. Next slide. Well, we don't have paediatric surgeons in our hospital, and our local referral centre won't take him. He's too complex, that heart history, we can't have him here. So we blue lighted him, and luckily he got there just in time. The operation went well. He had to have surgery. He lost a little bit of bowel, but he's doing okay. Next click. But the moral of the story is as goes. Maybe it isn't always the takeaway. A paediatrician often has a riddle to unfold. We might not get the clearest history from our patients, and maybe we're swayed by the responses of others, and we get many red herrings along the way. Common things are common, but we see weird and wonderful things too, and often have to think outside the box. Next slide. So back to where we started. You want to be a paediatrician. You love the variety of medicine. We're worried about the coughs, the colds, the wheeze, the poos. Well, we have that. But we also have cases like Bob. Bob is your guy. Now, this presentation is really rare, don't get me wrong, but detective work in our job really isn't. We have multiple interesting conditions that come and present to us, and they're all part and parcel of being a paediatrician. In this case alone, we've seen a child with a surgical problem. Okay, I do have a disclaimer. If you go into paediatric training, you won't be a paed surgeon. But we do see so many children with conditions that can be surgical that we have to assess and call our friends, the paed surgeons, to help. But also, Bob had so many other conditions all in one that as a paediatrician, you'll see and dabble in along the way. Genetic condition, an infectious disease component, learning difficulties and developmental concerns, cardiology, gastroenterology. So as you'll see, we do see cute babies, we do see funny children, and don't forget our cool adolescents. We see our fair shares of coughs, colds and tummy bugs, but many times there's more to see and learn, often all wrapped up in one. And if you enjoy it all, Paediatrics is the place for you. Next slide. Thank you.
Thank you, Sagan. That was great. Another wonderful example of exactly how varied and interesting paediatrics can be as a specialty. So thank you very much to all three of our speakers. We have got a couple of questions. And the first one is for you, Ian, if you're able to unmute yourself and join us back in the conversation.
Yeah.
So we've had a question asking, would you on some occasions keep the child for a few hours for observation even when blood results are normal, or perhaps when the child has low-grade pyrexia or the parents are concerned?
Yes, is the short answer. As we said, one of the sort of your discharge criteria is the child remains well and the rash doesn't spread. And so certainly hanging on to them for a few hours to make sure that the child does remain well and the rash doesn't spread, even when you've got normal bloods, is not unreasonable. And I think the more you do paediatrics, the more pattern recognition you get, and the more you think, this child just smells a bit funny. They're not quite right. I don't know why. The bloods are telling me they're all fine. The obs are all normal, but I'm not happy. Listen to your instinct. As I said, when we did the original study, we had no guidelines. We just treated them as we thought was the right thing to do. And actually, even back then, we got the vast majority right. So I think it's very reasonable to keep them in your department or keep them overnight and admit them if needs be, if you're not happy.
Great, thanks very much. So I'm sure that's answered that question very comprehensively. The other question we've got is actually not particularly related to tonight's. It's somebody asking if there have been any plans yet confirmed about the application interview process for paediatrics this year with COVID going on. That's one for me to answer, but unfortunately I haven't got an awful lot of sort of hard and fast information yet. A lot of the decision making is still going on within HE and the other medical boards around the country. I think the desire is to try and do some form of interview, whether it's remote or face to face, but obviously there's a good chance that things will be different next year. I think if you didn't hear the first of our podcasts that we did, webinars we did about paediatrics, we did talk about the application process then. And I think the one thing to just hold on to is the fact that we will be trying to ensure we still test exactly the same areas. So stations might be slightly different, I suppose, but you know, do still look at the guidance and so on that's on the website, so you know what sort of things to prepare yourself for. But I say unlikely at the moment that there'll be anything hard and fast up before kind of probably late August, the way things are looking at the moment. But yeah, keep an eye on the website and keep listening to these webinars as well, because I'll try and update you as we go along the next few weeks, because obviously I'm sure that's something that everybody's interested in finding out more about. The other question that came up was just to see the CT findings, so I will flick that slide back up in a second. But otherwise, I'll just say a big thank you to all our three speakers again. Three really interesting and very useful talks. And just to say that this webinar will be up on our YouTube channel along with all the other ones in the next week or so. And tune in again in a couple of weeks' time when we'll have number 5 in the series. So any other questions, do feel free to drop into the college. And all the best for your Wednesday evening. Thank you very much. And I'll just pop the CT scans up again. There you go. I don't know if Segan, you had anything else you wanted to say about those CT scans. I think the person who was looking to see them again lost signal while that came on. So
yeah, so it's just on the initial contrast CT. You can see that there's lots of different bowel segments that you can see. On Bob's CT, you can see there's kind of, it looks like a kind of bean or kind of kidney dish kind of sausage shape in the middle, with the 2 arrows are pointing to the kind of parameters of it, which was the loop of bowel that at both ends there was obstruction, and therefore there was fluid building up in between it. So that's why you see that big kind of sausage area that you wouldn't see in a normal CT scan.
great, thank you very much. Super, thanks everyone. Take care.
Thanks.
Thank you.